All right, thanks, Joe. So I've got some disclosures here. I've worked for just about everybody, and I like them all the same or not. Of the drugs I talk about, only a few of them have indications for status, and if we just talked about those, it'd be a very boring talk. This is the first known description of status, and some of you know that I've been around a long time. This is actually my first paper. And if you want to just get the take-home point here, you get to the bottom line of this paper, which is give lorazepam, and now you can go to sleep. Well, status is either a continuous seizure lasting for some duration or repetitive seizures without recovery. What that duration is really depends on why you're studying status. For example, the San Francisco pre-hospital status study, if the patient was seizing when the paramedics were called and was still seizing when they arrived, that was considered status with a mean latency of about 5 minutes. Well, it turns out that that is actually quite reasonable in that if you look at the likelihood that seizures will end spontaneously, after somewhere around 7 minutes or so, it becomes very unlikely that a seizure will end on its own. So waiting for 30 minutes to treat, which is what I was taught to do, is clearly wrong. Is there some balancing point at which the risk of the drug actually exceeds the risk to the patient of the seizures? It's very hard to find that point. We tend to chicken out at about 5 minutes now. If we look at the whole population with status, this is from a couple of studies at UCSF, but it covers all of San Francisco. Anticonvulsant noncompliance or ethanol withdrawal are the two leading causes. Luckily for us, these are typically conditions in which giving a GABA agonist will rapidly terminate the seizure, so over half of the time we get pretty easy control. These other things, which are much less common, are also ones that are associated with the more difficult to control patients, and that has a big influence on the prognosis of the condition in that the ones who are harder to treat medically also have underlying conditions that are more likely to produce mortality. In the couple of population studies that have looked at various issues, it's clear that age turns out to be an important predictor of incidence for status, that the elderly have a much higher incidence than younger people. There is a tendency, at least in that Richmond study for African Americans, to have a higher likelihood of status, and the Richmond group thinks that they have isolated a small number of genes that confer a higher risk of status. If we look at it from another direction, this was a study in which the patients in a medical and surgical set of ICUs had EEGs done if they were in coma but had no reason to suspect status, so neither anything that was noticed like a seizure or any history of seizure activity, and yet 8% of those patients turned out to be in non-convulsive status, even when people thought they had another reason for the patient to be comatose. So it's actually important to get that EEG. How many of them need to be monitored? We could argue till the cows come home. Taking a division between what seems like early status, let's say the first 20 or 30 minutes, to status that has become self-sustaining. Early on, you may see generalized convulsions, but as time goes on, without treatment, the motor manifestations will diminish. You may just see some myoclonus, and eventually you'll see what's used to be called electrical mechanical dissociation, but in deference to our cardiology colleagues, we'll just call it twitchless electrical activity. So the patient is still seizing, they're just not moving. The EEG manifestations initially start as discrete seizures and then go on to a variety of patterns, some of which, like the periodic discharges, are by themselves not really suggestive of a seizure. And it's important that the EEG people you work with are aware of this. Early on, you have a big outpouring of cortisol and catecholamines, so you see a lot of stress responses, but after about 30 minutes, you start to see a fall in blood pressure. You get actually hypoglycemia from exhaustion of gluconeogenesis, and you may develop rhabdomyolysis. Initially, you get an increase in cerebral blood flow related to the hypertension, but over time, you actually get a fall in cerebral blood flow below that necessary for vegetative processes, and the seizures themselves will start metabolizing the brain to keep going. For that reason, you see more significant damage to the brain related to the seizures themselves with longer durations. If you just look at the 5-minute cutoff, or think back to the graph I showed earlier, about 25% of seizures that have already lasted 5 minutes are going to end spontaneously, but the numbers are decreasing rapidly as time goes on. By the time you get out to 30 minutes, in this one study, 7% of seizures that lasted more than 30 minutes stopped without some sort of treatment. Early on, the GABA agonists are quite effective in terminating seizures, but over time the GABA agonists fail, and perhaps general anesthetic drugs that have some effect on NMDA receptors may turn out to be more effective. The mortality goes up about tenfold when you go across this 30-minute threshold, but again, that is contaminated by the difference in etiology of the status and not simply a result of prolonged seizure activity. There is cardiac pathology that occurs as a result of the catecholamines that are released, and in fact what you see is the same thing you see with pheochromocytomas, with subarachnoid hemorrhage, with tetanus, and even with so-called voodoo death, where people have a tremendous fright and just die. You get these areas that are termed contraction band necrosis. This is not related to coronary ischemia. It's actually hypercontraction of myofibrils. It does cause a troponin leak. It's not in a coronary distribution. Its only EKG association appears to be with QT prolongation and doesn't require specific treatment. But just keep this in mind as a reason for why the troponin may be elevated. The EEG stages I mentioned before go from pretty obvious discrete seizures into ones that appear to merge together. I left these in the handout, but I took them out of the talk because we don't really have time to go over them. There isn't a commonly accepted classification for status, but I think there are some useful categories. So everybody can recognize generalized convulsive status. On the other hand, there's simple partial status, in which my thumb has been twitching for 5 years. It's going to twitch for another 5 years. I can get general anesthesia and it'll stop, but as I start to wake up, my thumb will start twitching again. And there's really nothing to be done about it. People have undergone resection of the cortex for that, and some of them are left with a plegic arm that still twitches. So it's not really clear what's going on there, but that by itself is not an indication for general anesthesia. Myoclonic status is either the end stage of a progressive myoclonus epilepsy or what you may see in someone who's had a severe anoxic episode. Suffice it to say that in the hypothermia era, this no longer appears to be a death sentence, and in fact there have been now many cases published of complete recovery in so-called myoclonic status after cardiac arrest in which hypothermia was used as treatment. The wastebasket of all this is non-convulsive status. There are a couple of identifiable syndromes. Complex partial status is really a complex partial seizure that just goes on. These are the people who suddenly 3 days after they left home find themselves in another city. Absence status, which is like typical childhood absence with the blinking and a 3 per second spike in wave pattern, except it occurs in adults. This is one to keep in mind because it doesn't respond to the typical drugs very well, and in fact some of the standard adult epilepsy drugs will make it worse. And then there's everything else that we tend to see in the ICU in people who have some other neurologic problem, perhaps subarachnoid hemorrhage, head trauma, etc., and go into status often without a convulsion. These are treatment data from the San Francisco pre-hospital status study in which patients were randomized either to a placebo, to a little dose of diazepam, or a little dose of lorazepam. These could be repeated once each. Even when they were repeated, though, they were at about half the dose we would normally use for the treatment of status. So the fact that they worked at all is pretty amazing. But if you look at the primary outcome, were they in status at the time of arrival in the emergency department, 79% of the placebo patients were still seizing. We'll look at a time graph in a minute, but this corresponds quite well to the notion that these seizures, once they've gone on for 5 minutes, are unlikely to end on their own. So even at about 30 minutes by the time transport was over, 80% of these patients were still seizing. The diazepam group, even though these were small doses, and the lorazepam group, which had the best efficacy here, there were statistically significant drops. Still not the numbers we'd like, but again, this was the first trial of doing this in an out-of-hospital setting, and our subsequent trials are actually going to higher doses of the drugs. If we look at any point in time, the placebo patients, as I mentioned before, tended to keep seizing until they got to the emergency department. and then they got some more definitive treatment. Lorazepam was always the most efficacious of these drugs, and that's why I would recommend it as the first-line therapy. Looking at pre-hospital complications for these patients, you were more likely to get intubated in the placebo group, which may reflect the fire department or paramedics' fear of taking a seizing 400-pound patient down 10 flights of stairs without having control of the airway. So what should we do here? Well, obviously you want to control the airway, but in this circumstance, rapid anticonvulsant treatment may in fact be the best way to get control of the airway. The patient won't need to be intubated most of the time, and as a consequence, giving them their treatment first rather than getting the airway first is probably the thing to do. If you decide you need to intubate with a neuromuscular junction blocker, you need to assume that the patient is still seizing even though they look relaxed. That's why they're called relaxants. So you need to keep treating them as if they're still seizing. I would recommend using a non-depolarizing blocker. Every year or two there are cases reported of fatal hyperkalemia. You don't know their past medical history. You don't know if it's really safe to give them a depolarizing blocker. Just take the extra time it's going to take to wear off and use the non-depolarizers. If the patient's hypotensive, you're in big trouble. They've either been seizing for more than an hour or they have some other problem causing the hypotension. Either way, they're going to need to go straight to the ICU and get volume replacement and probably pressors. On the other hand, if they're hypertensive, that's an expected response early in status. Don't give them antihypertensive drugs. Control their status first. Most of them are going to end up not needing antihypertensive drugs. Plus, if they end up on mechanical ventilation, then they'll have the decrease in venous return associated with that. Always check the blood glucose. All right, here's our first question. The drug of first choice for the treatment of generalized convulsive status is diazepam, lorazepam, phenytoin, midazolam, or phenobarbital. Good music today. All right. So I'm with 96% of you here. I was taught that you should use phenytoin because you're not going to get respiratory depression. You won't get somnolence from it. And these were things that were said by doctors who never gave the drug intravenously. You'd certainly get sedation from it. Midazolam is a good choice in refractory status. We'll come back to that in a minute. So, preferred dose of lorazepam is which of these? 1 milligram, 2 milligrams, 0.1 per kilo, 0.2 per kilo, or 0.3 per kilo? All right, well, I'm with 70% of you here. These might be doses you'd give to somebody who had confusional state and you're trying to figure out if they're seizing, so you want to give them a little bit and see what happens. There actually was an older trial that compared giving basically 8 milligrams to 16 milligrams in adults. The 16 milligram dose was no more effective than the 8 milligram dose. So if this dose doesn't work, then I'm going to go on to something else. But if the patient's in generalized convulsive status, I'm going to give them the whole dose. It takes a couple minutes. You need to dilute the lorazepam in an equal volume of whatever is in the IV because it's very viscous. All right, so lorazepam, 0.1 milligrams per kilo. I already mentioned those other things. Why do I say that with such assurance? Well, based on the VA cooperative trial, they compared 4 treatment regimens for the treatment of status. The patients were stratified into overt status, meaning my mother would know they were seizing, and subtle status, which meant either they had some pre-existing brain injury or they had been seizing for a long time, and either way they weren't in convulsive status that was obvious without an EEG or an experienced neurologist. These are the overall response rates. We'll just look at overt status. 65% of lorazepam patients responded. Phenobarb was next at 58%. Diazepam followed by phenytoin at 56%. Phenytoin alone, what I was taught to do, only got 44%. And in fact, I don't think phenytoin has a role in the termination of status epilepticus. It's a reasonable drug to use to try to prevent recurrence once you've gotten control of it, but it has no advantages and many disadvantages over the other agents we might use. Another way to look at the patients, though, were based on the EEG patterns when the EEGs were hooked up. The discrete seizure pattern, which is the earliest one, resulted in 75% of the patients being treated successfully regardless of what drug was given. But the longer they'd been seizing based on the progression of the EEG patterns, the less likely any of these conventional anticonvulsants were to work, which leads to one of my major dictums, which is you have one chance for a conventional anticonvulsant. Right? And I'll show you some sub-studies that look at sequences, but basically, if the first one doesn't work, you're not going to have time to expect the second one to work. And if the first one fails, whatever you've given, you need to move directly to general anesthesia. So some people want to give phenytoin after that. This is a good way to waste time. Fosphenytoin is useful when it extravasates. It doesn't cause a problem, but other than that, it has no better safety record regarding hemodynamics. So if we look at the aggregate of the first drugs, the response rate was 56%. The second drug was given in a sequence, so if you got diazepam followed by phenytoin as the first arm, you didn't get phenytoin as the second arm as well. But regardless of what you got as the second drug, only 7% of the patients responded. And if you didn't respond to the first two drugs, only 2% of the patients responded to conventional anticonvulsants. So there is no point, and let me say it again, there is no point in giving a second conventional anticonvulsant, even if you were raised from little up that the patient had to get phenytoin or you'd go straight to hell. Again, about 20% of the patients remain in electrographic status after they've apparently stopped twitching. Well, when does status become refractory? There isn't a standard definition. Most people have required failure of a benzodiazepine and phenytoin, which means they've required failure of the benzodiazepine because the phenytoin was useless. Some have asked for a third drug. You've already seen that's just a waste of time. If you look at the etiologies of refractory status, now something that we have always called infection comes to the top of the list. As I'll show you at the end of this talk, most of these patients really aren't infected. They have some inflammatory condition, but it's not an infection. The drugs that have been prescribed for this have included high-dose barbiturates, high-dose benzodiazepines, and propofol. So that gets us to the next question. The loading dose of midazolam for refractory status is 0.05 milligrams per kilo, 0.1, 0.2, 1 milligram per kilo, or 2 milligrams per kilo. So go ahead and vote on this. All right, well, I am certainly with the plurality of you. As you might imagine, this is a pretty whopping dose, right? So you'd be giving me 20 milligrams of midazolam. You know, it's not a misprint. Even worse than that is the tachyphylaxis, which leads to huge doses where you're basically popping the top off the vial and pouring it into the machine, which usually leads to a switch to some other therapy. So the high-dose benzodiazepines, we talked about the loading dose. This isn't a misprint. That's a huge dose, but that's what works. There's one paper that has looked at lorazepam as the drug of choice here, and Doug Labar said you could get seizure suppression with up to 9 milligrams an hour. I've never gotten this to work. If you give enough lorazepam to equal these doses, in effect, as far as seizures, you'll have a whopping metabolic acidosis from the propylene and polyethylene glycol in which the lorazepam is dissolved. This was a study from Columbia in which a group of patients who were considered refractory were treated with intravenous midazolam at these relatively high doses. Of 33 patients, 27 initially responded, but 13 of them broke through, and there were actually several breakthroughs. So they had to keep upping the dose. In this study, they only went up to 0.4 milligrams per kilo. They now go substantially higher. Well, how about propofol? This study from Mike Stecker at Penn used doses up to 250 micrograms per kilogram per minute or 15 milligrams per kilogram per hour, and appeared to be safe and relatively effective. We did a retrospective analysis and found that the propofol mortality was substantially higher, even though the initial seizure control was no different. That's probably a reflection of propofol infusion syndrome. So we tend not to use it as a first-choice drug, but rather reserve it for people who have failed midazolam. More recently, we've been using more ketamine. Ketamine is our only really useful NMDA antagonist. There are a couple of oral drugs that have NMDA antagonist properties, but you can't get them in at an adequate dose. So this, as I mentioned earlier in the day, doesn't cause an increase in intracranial pressure in patients who are on controlled ventilation. Exactly how much to give really isn't clear. Valproate is something that people are getting more interest in. We're in the midst of planning a trial that will compare second-line therapies, so people who have failed something like lorazepam will get randomized to one of these other drugs in order to figure out what the best second-line drug should be, and valproate will certainly be part of that. Topiramate is only available for oral use, so you can put a slug of it down a feeding tube. These folks use 1,600, so we put down 2 grams. Sometimes you put it in when you go home at night, and in the morning the patient stops seizing, and sometimes they haven't. Levetiracetam is the darling drug of neurocritical care right now. It seems like if you have any reason to be in the neuro ICU, then you certainly have a reason to get intravenous levetiracetam, and the more the better, and there's not a lick of data to support what we're doing here. All right, so if you look at the studies that have been published, they've given between 1 and 6 grams a day. I'll guarantee you that an adult on 6 grams a day is going to be the meanest son of a bitch you've ever seen. So this study, looking at patients who are mostly refractory, found that the intravenous levetiracetam terminated 65%. So that's pretty decent. As I said, there's not yet a head-to-head trial, but this will be in our proposed study of second-line agents. Whether it ought to be a first-line agent, we don't know yet. This is a paper in the literature, and it's used as a reason to think that levetiracetam ought to be a drug that we use for the prophylaxis of patients with head injury. I just point out that there's a small problem here in which the mortality of the levetiracetam group was a lot higher than that of the comparator group that got phenytoin. So if you survived that initial treatment, then levetiracetam might be better. But until this mortality issue is sorted out, whether it's related to the drug or not, it's hard to just endorse it. So it's not statistically significant. You'd have to study over 400 patients in order to figure out whether this is real or not. But it does give me some pause whenever I see people on levetiracetam. Lacosamide is our new slow-acting sodium channel antagonist. Maybe it'll be useful. Don't really have much experience with it yet. Other drugs might be useful. This suggested that verapamil was useful in a patient who got SVT. They gave verapamil and it broke the status. That might work, but also remember that drugs like verapamil displace protein-bound drugs like anticonvulsants. So it may well have been that this patient just got a huge surge in the free and therefore brain levels of the drugs that he was already on when the verapamil was given. Hypothermia has been tried. Basically, you stop seizing when you're cold and you seize again when you warm up. But it's a good way to buy some time if you're not able to get control. Easy to put people on ketogenic diets when they're just getting tube feedings, and very hard when they're eating their own food. You could do ECT. That's been tried. I used to think this was a bad idea. The last thing I wanted was more synchrony, but in these case reports it seems to have worked. I haven't tried it yet myself. I put this out last year, and by the time it was published a few months later, my list of things that were autoimmune disorders associated with status was already way out of date. But a lot of what we used to call infection has never had any actual organism detected, and now it's becoming clear that a lot of these patients have some sort of either anti-receptor antibody or other autoimmune phenomenon that is the trigger for their status, which has led to a lot earlier treatment with steroids when an etiology isn't found, and has led to the widespread use of intravenous immunoglobulin. There are several papers, most recently, Joseph Dalmo, who's at the University of Pennsylvania, is the author of half of them, and Angela Vincent at Oxford is the author of the other half. But I think this is going to turn out to be the biggest eye-opener in our refractory status group, that we were never actually treating the etiology. It'd be sort of like treating septic shock with pressors and not doing source control. So I won't try to go through all of these because even I can't remember them all anymore. It's worth remembering, though, that this group of conditions is likely to be the cause of refractory status unless you know of some other one, and to think about immunologic workup and treatment early on. So you can give all these things for it. Most people are now throwing the kitchen sink when the people don't respond. Finally, there have been other things that have been tried for refractory status. There are 2 randomized controlled trials of lidocaine. I've never gotten it to work. I don't bother anymore. People have used high-dose phenobarb. If you can get paraldehyde, it works well. Some countries that don't have intravenous lorazepam try to use intravenous clonazepam in a similar way. A few refractory patients have been treated with isoflurane or desflurane. This is fine if you have an anesthesia background. There is a new device on its way out called the Anaconda, which allows you to make a closed circuit on a regular ventilator for these inhalational agents, so they may actually turn out to be useful not only for refractory status but also for ICU sedation. Magnesium will produce great neuromuscular junction blockade, but it is not an anticonvulsant. The patients with eclampsia or preeclampsia who get magnesium are having treatment of their underlying disease, so they have fewer seizures, but it doesn't function as an anticonvulsant outside of animal models where you've really depleted them completely of magnesium. There have been various surgical attacks on this. So a few practical things. Your patient's going to get hypotensive, so be ready to deal with that. All these drugs are great immunosuppressants, so they're going to get infected. If you don't do EEG monitoring, you'll have no idea what's going on, so if you can't do it, you send the patient to a place that can. And unless the patient has some known devastating CNS condition or you see that their brain is melting away on serial MR scans, don't stop. We all who do this have got patients who were in high-dose barbiturate comas for 4 weeks, 5 weeks, 6 weeks, who are now back at work or back at school, including my friend Lizzie here, who had Eastern equine encephalitis, spent 4 weeks on pentabarb to control her seizures, and graduated with her class from the University of Virginia and is now a lawyer in New York. If she hadn't ever seized, maybe she would have been a doctor, but who knows. Thank you.